So after this informative session, we move on to the next session. It is the guest lecture on critical care. And I would like to invite the Honorable Chairpersons, Dr. Supriya Sarkar, Professor in HOD, Department of Chest Medicine, College of Medicine and Sagar Datta Hospital. Sir, next I would like to invite Dr. Tapas Banerjee, Senior Consultant Physician, Medical Super Specialty Hospital of Kolkata. And over online, we will have on the virtually, we will have Dr. Dipanjan Bandyopadhyay, Professor in HOD of North Bengal Medical College, joining us soon. And now I would like to request my respected chairpersons to please invite our learned speaker.
Good evening, everybody. So I have the pleasure to invite Dr. Dhruv Chaudhury, who actually needs no introduction. He is one of the most renowned pulmonologists of the country and a critical care specialist. He was holding several academic positions and several administrative positions in critical care. So we know him for a long time. So his topic is very interesting on oxygen saturation, partial pressure, and content of oxygen relative significance. I invite Dr. Dhruv Chaudhury to start his deliberation without any further wasting any time. Thank you, sir.
Thank you, Dr. Sarkar. And over next 20 minutes, I shall be talking about primarily the respiratory physiology or the physiology of oxygenation. First of all, thank you very much, Dr. Chaudhury Paul, to giving me an opportunity to discuss with my colleagues regarding an important issue of oxygen saturation, partial pressure, and content of oxygen. Primarily, it tells us how to assess hypoxemia in the clinical scenario. So let's look at it. What is important for us is that we need to understand the oxygen cascade or the process of how the oxygen reaches into our lungs, from there to the cardiovascular system, right up to mitochondria. Because for aerobic respiration, oxygenation is a must, especially for the oxidative phosphorylation which takes place and generation of ATPs. If you really look at it, from the air, it comes to the lungs, and from the lungs, it goes to the blood. And from the blood, it gets distributed throughout the tissues. And this is how, from atmosphere to the mitochondria, the oxygen takes place. And when you start looking at this declining oxygen cascade, when you see it starts from the atmospheric pressures. When you calculate the alveolar oxygen, it is roughly from the atmospheric pressures of 159 partial pressure of oxygen, because you see there are nitrogen and other gases. And if we calculate at the rate of 21%, it turns out to be 159. The humidification takes place within the upper respiratory tract, and by the time it reaches the trachea, it practically is fully humidified. And at that point of time, roughly the pressures are around 150. And then from there, the alveolar air goes into the arterial. There, the concentration somewhat starts going up into, and then the venous admixture takes place. So you see the pressure starts dropping from 149 to 100 to 97. And the significant tissue extraction of this takes place in the cellular level, at the peripheral level, and the cell PO2 usually happens to be between 5 to 20 millimeters of mercury. And if you monitor the mitochondrial oxygen, it is 1 to 2 millimeter. So you see, it's a very integrated, complex system. But if I look at it from the energy perspective, it is very inefficient, because from decline from 150 to 1 to 2 millimeter, everything is moving up. A lot of energy is utilized, but nevertheless, it's an excellent and efficient system. When you look at the gas exchange, most important is, as we are talking about, first, obviously, we look at alveolar air equations, then we look at alveolar arterial gradient, because oxygen will always move, or things will always move, or gas will always move when there will be either a pressure difference or a concentration gradient. And that's what is happening. And these two things are interrelated. That's what we see. And at the end of the day, when it reaches into the peripheral level, from the capillaries, it goes to the tissues and then to the cell by means of passive diffusion. Now, what one has learned over a period of time from the nature is that dissolved oxygen is not alone is insufficient to meet the demands of tissue metabolism. But nevertheless, the oxygen has to go from the lungs to the blood, and then blood from there, it goes to the hemoglobin, and that is where maximum it is stored. If you really ask me, and the data is very clear now that nearly 98 to 98.25% actually travels with the hemoglobin, and that goes in the form of oxyhemoglobin. So hemoglobin is a very important transport vehicle, which actually stores the oxygen, and then it takes it oxygen wherever the RBCs goes, because the hemoglobin stays in the red blood cells. Similarly, the pressure is important, which is there in the blood. Actually, that pressure or that forces it into the cells, into the hemoglobin, and that is important for us. And each hemoglobin, if you really ask, has got 4 protein chains which are united together by a heme molecule. And with each chain, with each heme molecule, there are 4 heme molecules. So 1 molecule of oxygen will be there. Therefore, 1 molecule of hemoglobin will be carrying 4 molecules of oxygen. That is important for us to important. And also we need to know that dissolved oxygen gas will exert a pressure in the vasculature, which we measure from the blood samples, which is called as the partial pressure of oxygen or the oxygen tension which is required. And it is the pressure which derives the hemoglobin, that drives the oxygen into the hemoglobin. That is point number 1. As I said, that there are 2 alpha chains and 2 beta chains, and they're all attached with the heme, each molecule. And when the oxygen starts getting attached to these molecules, to these heme molecules, structural transformation takes place. So a sequential as well as structural transformational, both these takes place, and that is responsible for looking at the classical pattern, what we called as an oxygen dissociation curve. In this, if you see, this is a sigmoid shaped curve, and the total, once the oxygen starts getting attached with it, it goes structural changes. And that is why whenever you find certain changes in the structure of the heme, like classical sickle cell disease, where valine is changed with the glutamic acid, what did you find? What do you find? Whenever there is a radical reduction in the oxygen, there will be structural changes occurring, which leads to the formation of sickling. And that happens when the oxygen levels are little low. So when you see it here in the normal one, the sigmoid shape, gradually you will see the oxygen is filled up. After a certain level of attention, whatever you may increase the partial pressure, this increase will not be there. So this is a relatively a smoother part of the straight linear part of the curve. And here it comes up the blunted or the plateau phase. And that is why when we define respiratory failure, because at the partial pressure of 60, nearly 90% is there. And if you keep on increasing the partial pressure, saturations are hardly going to go up. But equally important are the certain terms which we use in it. P50 is that when oxygen is 50%, so hemoglobin is 50% saturated. And we clinical definitions, we see to define various components on the basis of this, how much is the oxygen which is there. And also it helps us defining, is there any challenges in terms of oxygen delivery to the tissues? And along with it, if you see, these are the various components of oxygen dissociation curve. And 3 things become very, very important for us to understand. One is a pH. Second, obviously, when you talk in terms of carbon dioxide, it is an acid. So again, both HN and CO2 tells us about the effect of acid on this curve. And then you have a 2,3-diphosphoglycerate and temperature. Now shift, it can be shift to the left, it can be shift to the right. When for some reason it shifts to the right, then the association between the oxygen and the hemoglobin becomes less stronger and it gets shifted away and oxygen is delivered. If you have got increase in H-ions, that is means in these cases the pH is declined, again it's there. On the other hand, if you find that person has hypocarbia, person has reduced 2-DPG levels, or there is an alkalosis, the curve shifts to the left. Same thing happen when the temperature lowers down. Again, the curve shifts to the left. So left oxygen, less oxygen will be available or will be released from the hemoglobin to the tissue. So this is the fundamental, it is there. and it has a clinical relevance. If you see 2-3 DPG, if you are giving a blood transfusion, the stored bloods when you begin with, if they're more than 24 hours, there will be a significant decline in DPG levels. So if you give oxygen, if you want to improve the oxygen delivery to the tissue, and if you use a long-standing stored blood, results may not be immediately evident. That may take more than 24 to 48 hours before the 2 DPG levels are built up in the RBCs. Therefore, it is important to realize it that if some people, especially in neonatology, they look at it, it's most of the time the fresh blood or less than 24 hours storage to be used for exchange transfusion. Otherwise, you are simply giving it a mechanical load. Similarly, you will see that patients who have got alkalosis, patients will have falsely elevated saturations because oxygen content of the hemoglobin continues to be high. And the effect of acid on the delivery or H-ions on the delivery of oxygen in the tissue is the classical Bohr effect. We all know that within the peripheral tissue, because of oxidative phosphorylation with the ATP generation, there is a generation of carbon dioxide. And carbon dioxide is the one which is responsible, which is the H-ions, which leads to carbonic acid with its activity with the hydrogen away with water. So what it results in H-ions. So when it occurs, it shifts to the right and more oxygen is delivered to the cell. Opposite of it is the Haldane effect, which takes place in the lungs. What we realize is at this point of time, the carbon dioxide is released and the carbon dioxide transport occurs as a result of carbinohemoglobin, which is there. It gets attached and you will see there is a difference, what is called as veno-alveolar carbon dioxide gradient. And as the blood passes through the capillaries, this particular component of a higher content of carbon dioxide tries to move out, facilitating the rapid uptake of oxygen. And that's how the oxygenation takes place. So it is very important for us to understand these basic physiological effects when we are doing. You will say, what does it mean? Look at a classic example of a patient of COPD. You try to give them oxygenation and sometimes they worsen, and especially the chronic lung diseases. What do you find? The consequence of this is, especially when there is a CO2 retention in addition to VQ mismatch, you will realize that 10 to 15% of hypercarbia is actually occurring because of Haldane effect. Therefore, understanding of respiratory physiology, transportation of oxygen as well as carbon dioxide is extremely important from the respiratory pulmonology perspective, but also from the critical care perspective. Now, when you start looking at it, we are talking interchangingly 2-3 things. We talked about oxygen saturation. We talked about oxygen tension or partial pressure of oxygen. As I said earlier, the binding sites for the oxygen on the hemoglobin and the heme groups are the iron. That is the ferrous, porphyrin portion which is there, and that is where it gets attached. 4 heme sites are already there. I've talked about 4 oxygen binding sites per hemoglobin molecule. Now, percentage of all available heme binding sites saturated with oxygen is the hemoglobin's oxygen saturation. In words, whatever heme molecule which are there when they're attached with the oxygen, let's say if you have an X amount, how much of this X amount is actually attached with oxygen defines the oxygen saturation of the hemoglobin. And that is what you see. We have used different terminologies. What is SaO2? What is SpO2? SA2 means saturation arterial oxygen. If I put P, this is a non-invasive measure, that is saturation pulse oxygen. That's how we differentiate. So these terminologies are important, but to measure SaO2, we need to have blood which has to be taken from the arteries or the oximetry techniques. The second component comes an oxygen content in the blood. Now, what is important to realize that we have already discussed the 2 ways the oxygen can stay in the blood. One is your dissolved oxygen. First, obviously, it will go to dissolve, and from there, under the pressure of the oxygenation or the oxygen tension, it will go into the hemoglobin. It will get attached to the hemoglobin within the RBC. So majority, 98% nearly gets attached with the hemoglobin, 2% is dissolved. And when you see the 4 heme molecules with which oxygen combines, that is 1.34. So the amount of hemoglobin is let's say if it is 15, you multiply 1.3 into 15, and depending upon the saturation which you have monitored SaO2 per ml deciliter, that's how you calculate it. So this is the way we are calculating the hemoglobin which is bound to the oxygen, and the 0.003 is the constant which is there of the oxygen when it's dissolved in the plasma, and when you multiply it with the tension, because that is what is keeping it dissolved, give the oxygen content within the plasma. So when you combine these two together, that becomes the oxygen content. And in this, again, we calculate the two different things. The oxygen content, one which will be there in your arterial blood, and oxygen content which will be there in your venous blood. When you look at the oxygen content in the arterial blood, the one which will be delivered, this is roughly 20 ml per deciliter. And the basis of calculation again is the same. You multiply hemoglobin and saturation, which you have monitored, plus you also look at the partial pressure rate is 0.3 because you calculated PO2 100 at the sea level. Whereas when you look at the CVO2, that is the oxygen content within the veins, that is the one we calculated, turns out to be 14.8. Here again, primarily the difference will be coming up because the mixed venous oxygenation pressure, when you start looking at it at that particular point, is around P40. That's why it is turning out to be 0.12 ml instead of 0.3 ml. And roughly you can see it will be 2.5 times of what you have observed there, or 1/4, which is there. And then second, which will be important for us, will be that the pressures have gone down, saturations have gone down. If you take it roughly 70%, so the total oxygen content of the veins will be, venous blood will be 14.8. That means roughly 5 to 6 liters has been per deciliter has been taken by the tissue that has been utilized. This is how we know the difference between the oxygen content of the arterial side and the venous side tells us the oxygen consumption which is taking place. But there another variable, that is the cardiac output, takes into place. So you start looking at the consumption, you calculate how much oxygen has been calculated, Q is your cardiac output, and that is the difference between, as I said earlier, has been between the arterial content minus the venous content of oxygen. And it does not include the consumption of the lungs, so it has its own, but from the hemodynamic and clinical parameters, when we are looking at the etiology behind the hypoxemia and oxygen devices, or the delivery of oxygen utilization taking at the tissue, it becomes practically much easier for us to do at the bedside. Another one people have tried to use from here is how much oxygen extraction is there. This is classically you tend to see when delivery is less, the tissue tries to make it down. And here what you see, the delivery, what is the oxygen consumption minus divided by the delivery of oxygen. Now the consumption again will depend upon it. We calculate and simplify it is that what is your saturation oxygen, arterial oxygen minus mixed venous oxygen, you divide it by the saturation oxygen which we have monitored. And now if you have a centralized, you can always calculate SpO2s, and on an average in between, the normal extraction ratio is 20 to 30%. That is why when person has anemia, you will see the SpO2 levels go pretty down, extraction ratios goes up, and tell you that there is something wrong with the tissue. So the deliveries may not be there. On the other end, when you take a person of a septic shock, because there may be peripheral shunting taking place. So initially you may find SpO2 may be normal or paradoxically elevated, and normal OER may be there. So we must understand the pitfalls which can happen when we take each of them. Now, another important thing which starts coming up when you start looking at in terms of oxygenation and the oxygen physiology is a shunt physiology. And we all know that ventilation perfusion mismatch has to be adequate. And that's what we find in a healthy alveolus: adequate ventilation, adequate perfusion. When you have a collapsed alveolus, what we find, there is no ventilation, but all oxygenation. And that is what is called as a shunt. And obviously, the most important clinical parameter of a shunt is in patients of severe ARDS, pneumonias, lung contusion, etc. The extreme of this, the other side of it, is a dead space where you see there is no flow and there is all ventilation. Pulmonary embolism, low flow states are classical examples of that. So it is important for us is that two things have to interact very closely: the ventilation, the distribution of ventilation, and perfusion and distribution of perfusion. Now, I think we will simply look at it. Another thing which we all talk in terms of physiology is a shunt fraction calculation. For this, we used to do a fixed principle that have been used for this, but nevertheless, what is important is for calculation of shunt fraction, quite often we need to do an invasive cap. Here, when you see CC2 is nothing else, but these are the post-capillary oxygen concentrations, because this is post-oxygenation. And the difference what is there between the post-capillary, that is the when you start looking at a post-pulmonary capillary minus arterial content ratio to the post-capillary minus venous content, that is called as a shunt fraction. And obviously that tells us you give whole 100% oxygenation and then you try to find out what is the true intrapulmonary shunt. Normally 2 to 3% shunt is there. The importance and value of it is in patients of a congenital heart disease, but more important now today, we need to look at in the clinical perspective, how much is the shunt there? Routine, we don't do it, but this has an important clinical cardiopulmonary implications. And normal, again, the same formulas will be there, but pulmonary and capillary oxygen content are supposed to be the same as is the alveolar content. That is what our extrapolation. But for you, this, you need invasive one to do the techniques. And nowadays we are getting surrogates for it in terms of calculated ones, which are coming up in terms of clinical practice. Now, shunt fraction calculations, you do it. I will not go into more details about it. And normal shunt fraction should not be more than 2 to 3% up to 5%. If anything which is more than that means there is something wrong. And these are the ones which you need or required majority of the time happening intrapulmonary shunts which are there. Now, once it is there, this is the summary of oxygen transport which takes place and which all of us as a clinicians and physicians and critical care intensive specialists need to know. Now, this is a summary of what we have discussed. You have a dry air, gets humidified, goes to the lungs. There is a red one is the one obviously deoxygenated blood. You have a function shunt of 2 to 3%, then it goes. Proportional pressure of oxygen, once it starts coming up into the arterial side, is nearly 98 to 98.8. This is the P50 we're talking, saturations, which will be 97%. If you're finding 100% saturation, that means there is more of our oxygen somewhere has got involved or have mixed with it. And from there you calculate the content. This is your cardiac output. This is the oxygen delivery, roughly takes place a liter to the tissue per minute. And then the diffusion takes place to the capillaries. The arterial end of the capillaries is 98 and the venous is 40. It goes to the mitochondrial cells, pressures are 10 to 6.3. And this is the utilization. So if you will see at this rate, the oxygen utilization on an average is 250 ml per minute in a 70 kg man with a hemoglobin of 15 grams with a cardiac output of 5. And then this is where the oxygen returns, mixed oxygen saturation you will see. This is 40, this is a normal physiology. And this is how the things keep on going up. So you have, it gets the bad blood, it gets oxygenated, it gets the good blood, the metabolic activity takes place within and close to the affinities of the microcirculatory mitochondrial phase. And from there, once it is utilized, the tissue utilization, oxygenation, use formation of ATPs, cellular health is maintained, and that's how the cycle is maintained. Now, it tells us what we had started discussing here. So when oxygen level is less, we call it as tissue hypoxia or hypoxemia. And we are already talking about the normal delivery is around 1,000 ml per minute. Therefore, when we have a failure in oxygen delivery, that is what leads to what is called as tissue hypoxemia. So that means it can either be a failure of oxygen content, or there is a problem with the delivery devices in these cases. So when you start looking at it, either it is a poor oxygen delivery. Commonly, you look at in terms of patients having a low cardiac output state. It can happen. Peripheral circulatory failure, shock of any origin can be part of it. Anemia again is an important component because the oxygen content reduces significantly. And similarly, low oxygen states, saturation states can also, like sickling, it can cause it. Similarly, persons have methemoglobinemia, if you see, it is not carrying that much amount. And similarly, in other hemoglobinopathies, you can see it. Similarly, if there is an inappropriate oxygen utilization called a hypoxic Hypoxemia, which takes place at the cellular level. Cyanide toxicity is one example. Along with it, if you see with the carbon monoxide, but carbon monoxide also could be part of poor oxygen delivery because it has more than 200 times affiliation to the hemoglobin. And that's why hyperbaric oxygen is a treatment of choice. Similarly, in sepsis, I told you there's a decreased utilization and excessive utilization when there is an increased metabolic rate in thyrotoxicosis and fever. So the question comes of the assessment of tissue hypoxemia. So you measure arterial oxygen concentration. That is called as SCO2 is an oxygen saturation and PO2 is a partial pressure of oxygen. We also look at a serum lactate as a base deficit, but that is not the time right now to discuss about. Then you have an SO2 measurement non-invasively. When you use it, it becomes pulse oximetry, that is SpO2. But what is very important is that when you use certain toxin, they will disrupt this predictable relationship between SCO2 and PO2 as measured. Usually they go hand in hand. But remember one thing, when we are measuring SpO2, we are only looking at reduced hemoglobin and saturated hemoglobin to the total content. It cannot measure methemoglobin, sulfhemoglobin, or carboxyhemoglobin. So what it leads to a fixed oxygen saturation which starts, and it has led to a concept of called as saturation gap. So if you see your SpO2 is fixed sometimes around, let's say 85, 86, and SCO2 is more than 90, immediately look at that there is some abnormal hemoglobinopathy, in all probability likely to be methemoglobinemia. And again, when you start seeing it, methylene blue also, it will also interfere it. And that is why it is very important when you're doing pulse oximetry, there should not be any nail paint because it can also interfere with these absorption coefficients. Similarly, when you have got cardiac arrest or profound shock, you call it as an absence of pulsatile flow. And that is why you will see in pulse oximeters, they have written PI, pulsatile index, which is there, how much it is there, how much is the perfusion. And it is very important how you're measuring pulse oximetry. That's what COVID has taught us. It should ideally be looking at it in the middle finger because it's a dual supply. It should be warm, it should be there, and wait for a minute or so. After a minute, then you look at it, what is happening, what are the pulse oximeters. Similarly, if somebody has got an underlying cardiac disease, particularly pulsatility is very high, you can have low reading. Therefore, if you are finding that there are low readings which are not consistent, or if they're low reading and person is warm, please try to rule out hemoglobinopathies, look for saturation gap. And if the difference between SaO2 and SpO2 is more than 5, it is abnormal. Other assessment to look at hypoxemia from here, we have excluded is as a PA2-FiO2 ratio. That defines now today mild, moderate, and severe ARDS. And we realize that certain places blood gases is not possible. That was also true during COVID. And that is what is called as a Kigali modification. Here you see SpO2-FiO2. The ratio we define with the PA2-FiO2 is less than 300. Here we take it as less than 315. Another index which have come up from here is called as respiratory rate oxygenation index, ROX index, which we are using in high flow nasal cannulas and oxygenation parameters. So here what you do is you take the Kigali modification divided by respiratory rate. So if you see the values are less than 4.5 at a 4.8 at any point of time, that means probability of failure are high and this person is likely to have an intubation. So these are the small things which are helping us. Similarly, alveolo-arterial gradient calculation on the bedside is key to find out the cause of hypoxemia, whether it is primary hypoventilation or it is VQ mismatch. That's how immediately, straight away, you are able to know in patients, and then you try to find out along with dead space measurements. Hypoxemia versus hypoxia is another thing which comes up. Hypoxemia is abnormally low arterial tension in the blood. That's how we define. Hypoxia is the tissue oxygenation for cellular metabolism, and you cannot measure it directly. But what is very important is one is the observed value, another is a pathophysiological process. So this is how we look at it. We look at severe hypoxemia. Clinically, when defined respiratory failure is 60. But normal values we take up to 80 to 100. But as Dr. Jha was saying in previous one, follow sequential one. And anybody who is having a saturation consistently less than 94% or walking, it drops down by 3%. Look at it, underlying oxygen defect. So looking at it, you have a different hypoxemic processes, hypoxemic hypoxia, anemic hypoxemia. histotoxic or circulatory. So when you start looking at hypoxic hypoxemia, it is a low arterial oxygenation tension, which causes it. When you are looking at hypoxic anemic, it's a decreased oxygen content. So they're interrelated, but there are little differentiations also. When you start looking at circulatory hypoxemia, that means the tissue perfusion is adequate and it's consequence of shock. And histotoxic, as I said, is inability to dissociate sepsis or tissue ability to utilize oxygen. So there, what you're seeing is tissues are not able to use oxygen is there because the electron chain has gone.
Please conclude.
This is a summary of everything what we have discussed, how to differentiate between types of hypoxemia. So both are important: arterial oxygenation, oxygen content and saturation. In hypoxemic, all will be low, whether it is arterial PO2, venous PO2, content and saturation. In anemic, arterial PO2 will be normal, oxygen content will be low, saturation will be normal. So the differentiation between hypoxemic and anemic is the oxygen content, and cyanosis will not be seen. Whereas stagnant one, you will see it is the venous PO2 which is there because of the peripheral one, circulatory failure. In histotoxic, everything will be there, but the oxygen content, oxygen saturation will go up. So right sitting, knowing these three things on the bedside, you can differentiate the basic etiology and can treat patient accordingly. To summarize, therefore, friends, basic of physiology is essential. Adequate oxygen delivery is an integral function of respiratory, cardiovascular, and hematological system. And pitfall of measuring saturation should be crystal clear. In critical case setting, essential to dehyphenate hypoxia pathophysiology to make correct assessment and therapeutic decision. Thank you very much.
Thank you, sir, for nicely discussing oxygen physiology. And we know that when a physician sees a ABG report, they usually starts from pH, then the acid-base disbalance. But COVID pandemic has taught us to focus on oxygen, and you have nicely discussed the oxygen physiology. Now, oxygen in the atmosphere. Oxygen in the atmosphere is about 150, and in the upper airway, it is mixed with the water vapor, and in the alveoli, it mixed with the carbon dioxide, thereby it reaches 100. And there is a gap between the alveolar oxygen and arterial oxygen, that is called alveolar arterial oxygen gradient. And our is about it is the 1/3 of our age, roughly calculated. And you have nicely discussed the oxygen delivery and oxygen transport, and oxygen content is mostly dependent on the oxygen saturation and the oxygen dissociation curve when there is a shift to the right or left. And so thank you, sir. And if there is any question in the audience.
Only one question,
we can take only one question. And as there is no question, and Dipanjan is here. No, Dipanjan. So I conclude the session with many thanks to Dr. Dhruv Chaudhury.